Hi, my name is Elizabeth Morrison. I'm a psychologist, an LCSW, and an addictions counselor. And this is Trauma-Informed De-Escalation Part 2. In this video, we're going to focus on early intervention and middle intervention for escalations in the clinic. If you want to focus on prevention and self-assessment for engaging in de-escalation, you can listen to Trauma-Informed De-Escalation Part 1. The most important thing for early intervention in escalations is to recognize when people are starting to get angry. One of the things that people do when they start to get angry is they cut off their gaze with us. So if you're interacting with somebody over the desk in the front office or in an exam room and they look away, they seem sort of angry and they look away from your eyes, that's a cut off gaze. If people audibly sigh, even in our personal lives, we probably know that when people are angry, they, you know, audibly sigh. Pacing of any kind in an exam room, in the waiting room, on the sidewalk outside is usually a sign of agitation or anger. Staring. So if you look up, if you're at the front office and you look up and there's somebody sort of, staring at you, that can be a sign of anger. Irritable agreement is the equivalent of, whatever, that sort of thing. So anytime somebody says, that's fine, or whatever, I don't care, that's irritable agreement. Anytime somebody is repeating. So if a patient says, this is the fourth time I've left a message and nobody's called me back, and then a minute later in that conversation, they say, this is the fourth time, right? Anytime somebody repeats something, it's usually a sign that they're angry. Arguing, of course, even very low level arguing is a sign of anger. Shrugs, it's the equivalent, it's the nonverbal equivalent of irritable agreement. And then, of course, a raised voice. Even before yelling, when somebody's voice is raised, it is a sign that someone's starting to get angry. The reason that I'm sharing these examples, and there's plenty of others, like signs of people getting angry, is the most important thing for successful de-escalation is trying to intervene as early as possible in the anger. The earlier that we can address a patient's anger, the more successful we are going to be with de-escalation. So sometimes, of course, people come into the clinic loaded for bear. They are already really angry. Sometimes, like as soon as we pick up the phone, people are yelling. Most of the time, though, patients have an escalation. They start low and then it builds. And we want to get at it right when it builds. Now, what I will say is that most of us would like to ignore people getting angry, right? It's not pleasant. Sometimes we fear if we go in, they're going to get angrier if we actually address it. Sometimes we feel like if we ignore it, it will go away. That old idea that if you ignore a behavior, it's just for attention and it goes away. So there's a lot of conditioning telling us that when we see someone in the waiting room audibly sighing and who gets up and paces and sits back down, that we should ignore them. And I cannot stress the importance of not ignoring that. When we ignore signs of low-level anger, it often results in increased anger. So if we ignore it in the waiting room, then the medical assistant is going to get a higher level of anger. If the medical assistant ignores it, maybe the patient manages themselves for the provider, maybe not. But then when they interact with the billing person or the front office again to make an appointment, they get an even higher level of anger. So not only does it leave room for the escalation of anger, but it kicks the can down the road for our colleagues where they're going to get the worst of it. So we want to go in as soon as we see it. Once we're ready to go in and do something, we want to take just a minute and breathe really deeply to sort of calm ourselves down. We want to soothe ourselves. A lot of times I say to myself, okay, I'm going in, I'm going to do my best. I don't know how it's going to go. I know no matter what, I'm just going to do my best, right? This kind of self-soothing talk. And then we want to use some empathy hacks to see if we can wake up our empathy for this person. Most of the time when people are angry, we don't have a lot of empathy for them. And that's not because we're bad people, it's because anger tends to lower empathy. So when we are angry, we tend to have lower empathy. And when other people are angry, we tend to have lower empathy. So it's easy to have empathy with people who are crying or hurt. It's harder to have empathy with people who are angry. So we want to use some hacks to try to get our empathy back because we are going to be much more effective when we feel empathy for this person. So we can imagine this person as a child. I shared in part one that I imagine someone, if it's a man, I imagine that they're my brother. And I say to myself, how would I want my brother treated? Sometimes we can say to ourselves, like, who knows what their day has been like or what their life is like. So any way that we can sort of hack our brains and our hearts a little bit to get our empathy back with people, we're going to be more effective. We want to check our biases. We all have biases. It's normal. Bias, judgment, stigma, all of those things grouped together are negative attitudes and beliefs that we hold about particular groups of people, conditions, or characteristics. Some of us are conscious of our judgments. Some of us, or most of us, have a lot of unconscious bias and judgment. So it's hard to check things we're unconscious of. Anything we're conscious of, though, we really want to just take a moment and try to correct it. So if we know that we have judgments about people with addiction, if we know that we have kind of negative biases around, angry men, which is one of mine, then we want to just take a minute and see if we can sort of get that in check. Because if we approach someone with our bias intact, then we're going to be much less effective. And that's because stigma and judgment and bias are the opposite of empathy. So the more empathy we have, the less judgment and stigma and bias we have. And the more stigma and bias we have, the less empathy. So what we're trying to do is hack our empathy and get it high and lower our stigma and judgment so we can be as effective as possible. Remember that we all have biases and judgments. So just we never want to say like, oh, I'm not a non-judgmental person or I don't judge. Like, of course we do. It's just human. We tend to think other people have more than we do. So it's just good to be conscious of that, just to know that we all have them and that it probably doesn't align with our conscious beliefs and values. So we probably don't want to have these judgments. We probably want to be totally non-biased. And when we tell ourselves that these three things, we all have them, we all tend to think others have more than we do, and they're probably not aligned with our beliefs or values, then it makes it easier for us to become conscious of the biases that we do have. This is a reminder from if you listen to part one. Remember that there is only a single goal of de-escalation, and that is the emotional and physical safety of everyone, including that person who's escalated or is starting to get angry, the people who are around us, like the patients who are around us, the staff, and ourselves. And that means that this is not the time to be right. No matter what, let go of being right. We don't want to argue with people and tell them why they're wrong, why what they're mad about, is like not even us, like it was the pharmacy's fault, or like we're not allowed to release these, records that they want, or like just drop being right. Ignoring, which we just talked about, we really do not want to ignore. We don't want to disagree with people when they're angry. We can disagree later if we want, but we don't want to disagree when they're angry. It makes people angrier. We don't want to explain rules when people are angry. We might call them later and do that, but this is not the time to explain rules. And we do not want to impose consequences. If you just think about like a fight you might be having with a kid, your own child or something, and like you're really angry and they're really angry, and you tell them that like they're going to be grounded forever, and it just makes people angrier. And so it is true, we might need to impose some consequences later. Like the clinic might decide that, this person needs to be warned that if they do this again, that, they're not going to be able to be treated. There might be consequences, but we never do it when people are angry. What we want to do instead is we want to help people reactivate their prefrontal cortex. So this is the part of the brain that is in the forehead. It's the part of the brain that manages emotions. It's the part of the brain that gets us to kind of act right, and not do impulsive, angry things. And so when people are angry, their prefrontal cortex is not active. They're acting out of kind of the back sort of, lizard part of their brains, that part that is like from like, just that we have in common sort of with any animal. So we want to help people get back into their prefrontal cortex. So some of these you'll recognize from part one. What we want to do is use their names. When we use their names and when we introduce ourselves or reintroduce ourselves to people, they have to think differently, and that is prefrontal cortex thinking. So if I say, hi, Mrs. Smith, I don't know if you remember me, I'm Elizabeth. Like if I say that, then she is going to have to start thinking from her prefrontal cortex to process what I'm saying. We want to apologize really quickly. I know many people We're not probably, or many of us were not raised with a lot of apologizing in our homes. So it's a skill that we're going to talk about later, but it's really important to apologize in early on in the de-escalation. Doesn't matter if we're right or wrong. We want to reflect feelings. We want to acknowledge that we hear that people are angry or frustrated. We want to offer something. Anytime we offer something to people, they have to use their prefrontal cortex to agree to it or to decline it. And we want to agree, especially with feelings. This is very difficult because sometimes people are wrong. But remember, this isn't, we agree as much as we can. So here's just an example about how we would reflect someone's feelings. If we see someone is angry, if they say they're angry, or if they say they're frustrated, or we just see it, we say back to them, "You're really angry. I hear you. You're really frustrated with us. I can understand why." Right? Like we reflect back to them that we hear their feelings. We normalize. I feel the same way if I were you and people hadn't called me back, or anyone would be frustrated, having their appointment rescheduled another time. So even if we don't think it's normal, even if we don't agree, remember our goal is de-escalation. We normalize and agree. And affirming can be very helpful. Affirming is another way of saying like a compliment. So I appreciate you sharing this with us, or thank you so much for kind of keeping your cool here. I know it isn't always easy. So even if we think people are acting angry, often people are trying to keep themselves from being more angry. And so if we kind of feel that people are doing this, we want to sort of compliment them. Once I said to somebody who was already yelling, but I saw his jaw clenched and it looked like he could be a lot angrier. I said to him, "Hey, I appreciate you keeping your cool here in the waiting room because there's kids here. And just thank you for doing that." And as soon as I said it, he was like, "Oh, yes, I'm really trying. I don't want the kids to see me angry." And then I was able to say, "Hey, do you want to walk outside with me? That way we can talk about it out there." So as soon as I complimented him, he started sort of de-escalating. So if you find an opportunity to affirm, do that. This is a picture of like a family having dinner, and like a family dinner. And the reason I share this picture is sometimes when we are reflecting people's feelings who are angry, sometimes when we are normalizing and apologizing, sometimes when we are agreeing and affirming, it doesn't feel very genuine, because this is someone who's angry and we wish maybe we could just say, "Hey, just leave," or, "Hey, I'm doing my best here." There might be other things that we might feel like saying. So sometimes it can feel a little ingenuine, just like if we're at a family dinner and we have some, racist uncle and we're like, "Yeah, yeah, Uncle Ted, whatever." Like sometimes we do this with family members just to keep the peace. Sometimes we just like, do this with patients to kind of keep the peace. So even if it feels ingenuine, keeping the peace and trying to de-escalate in a clinic is a really valuable and important thing to do, because if people get more escalated, then they're worse and they can really hurt people emotionally or physically. So just for some examples, how do we agree and apologize when we don't feel like it? If a patient says to us, "This phone system is the worst, there is no point in even trying to get through," how could we agree and apologize with that? We could say, "Gosh, I really hear you. I'm so sorry about our phone system. Even I can't get through when I'm calling." So it might feel a little ingenuine. We're kind of pissed that this is they decided to unload on us on something that we have no control over. And in blue is just an example of how we can de-escalate this so that it doesn't go higher and they're not worse with the next person they talk to, who's somebody on our team. So we say, "I hear you." We could say something like, "Oh, I can understand why you're frustrated. I'm so sorry." That's a way to reflect feelings. We get an apology in there and we normalize. "Gosh, I can't even get through." If a patient says, "Every time I come here, it's the same story. I am so sick of it," we could say, "Gosh, I hear your frustration. I'm so sorry. I'm so sorry you've had such bad experiences here. It sounds like it's been really terrible every time." So not only do we agree, we kind of hit it out of the park. We just say to them, "Yeah, you've had really bad experiences here. Man, that sucks. I'm so sorry." Like we just go all in to validate. Now, most of us have like a little thing inside that we like don't want to do that. It's like agreeing with them. We don't want them to be right. And this is why I say it takes a lot of practice to agree and apologize when we don't want to. And It's really important. And remember, a lot of times when I really don't want to say this, I remind myself, you know what? After this person's come down or after this person has left, after they've like come down and hung up, then we're going to debrief with the team and we may need to call that patient back, right? We may need to call them back and we may need to say to them, hey, or our manager perhaps, hey, you were beyond the bounds of how this person could be treated, of how we could treat staff in our systems. If that happens again, we may not be able to keep treating you. So remember, we may draw boundaries later. We may impose consequences later, but the moment when people are angry is not the time to do it. The biggest mistake most people make in de-escalation is jumping to fix the problem before sufficient apologizing, reflecting feelings, and normalizing. This is when a patient comes up and we have to tell them that their appointment was rescheduled and they say, God damn it, this is the third time that has happened. And we say, well, I can actually get you in tomorrow. We jump to trying to fix the problem before we say, oh my gosh, I'm so sorry. I would feel the same way. It sounds like this has happened multiple times. Gosh, anybody would feel like you. I'm really sorry. We've got to do that first before we jump to fix the problem. When someone comes up and says, how long is this going to be? I have to pick up my kid. I have been here for an hour and 15 minutes. If we say, I'll go to the back office and ask how much longer, we're jumping to fix the problem before we sufficiently apologize, reflect feelings, and normalize. We have to do that stuff first. Jumping to fix the problem doesn't make people less angry unless we do this stuff first. These are just some examples of things that we end up doing that make people angrier. Sorry. Just as an example, if we over explain, oh, the reason we have to have a mask is because the CDC guidelines, blah, 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 people get angrier. First, we have to say, I know, I'm so sick of masks too. I'm so sorry that I even had to ask you. I really apologize, right? God, such a bummer that we still have that rule here, right? That's what we want to do. We don't want to explain the rules. We don't treat everyone differently. When someone says to us, you treat me like this because I have Medicaid, that's arguing. If we ever tell people calm down, oh man, that's like a command, gets people really angry. Never say calm down. So this is just a list of things of really trying to stay away from these things because they make people angrier. And then just a word that we can set limits. If we are on the phone with someone and we're doing our best de-escalation techniques, we're reflecting, we're normalizing, we're apologizing, we're agreeing, and someone is still getting angrier or just continues to, kind of be abusive to us. If someone's doing that in a clinic, we can set limits. We set them with a really soft voice. We repeat them. We say, gosh, I'm so sorry. I really want to be able to help you. I'm not going to be able to keep talking to you if you keep yelling or swearing at me, but I want to be able to help you if you could stop. We say it, if they keep doing it, we say again, gosh, I'm so sorry. I'm going to have to hang up. I don't want to hang up on you. And if they keep going, we hang up. Now, we don't want to do that without warning people, without saying we're sorry. We can do this if we're in a room too. We can say, gosh, if you're not able to lower your voice, I won't be able to, stay in conversation with you. I really want to. I want to be able to help you. And if we repeat that a couple times and someone can't do it, we'll say, okay, I have to leave the room now. I'm sorry. And we leave the room and we go get a supervisor. So we can set limits. You are not supposed to just be, a punching bag for somebody at all. We just want to try everything before we do this. And then the last thing is, gosh, having someone yelling at us, having someone hang up, having someone, swear at us, having someone say something racist to us, having somebody slam a door, kick a garbage can, that stuff sucks. It's scary. It doesn't feel good. And so I just want to say that, after something like that happens, take some time, tell your team, I got to take a minute. I got to walk out around the block, or I got to take a deep breath, get support from people you trust, text your best friend, go find your clinic, your supervisor. If there's somebody that you really trust, go find your, kind of best work friend and just say to them, man, I just had a crappy interaction, and talk about it. Definitely document it as a critical incident. If a patient has been really rude to you, that needs to be followed up on. We don't want that patient to think that they can keep coming back and doing that. And so document it as a critical incident and forward it on to your clinic manager. And then definitely feel free to ask them, how does my clinic, how does my organization handle these things? What is the protocol for dealing with patients who are repeatedly abusive, rude, hanging up, say racist things, swear at us? Because there should be a follow-up procedure to talk to those patients. So definitely ask. There is on the Health Center Association of Nebraska on the website, like I said, there is a part 1 that talks about de-escalation and self-assessment of our own de-escalation skills, if you'd like to listen to that. There are some resources for, there's a tip sheet for de-escalation tips, and there's some resources for leadership too in developing follow-up protocols. And if you'd like to reach out to me for any reason or look at some more free resources on my website around de-escalation or trauma-informed care, you can email me at elizabeth@emorrisonconsulting.com or go to my website at www.emorrisonconsulting.com. Okay, thank you.